not a disease like heart attacks or lung cancer that you can do something to prevent. This is a disease that you need to know about.
Do men my age have to go through the embarrassment and the discomfort of a DRE?
Is it necessary for men of our vintage to use masturbatory practices in order to keep the prostate healthy?
We can get the urologist to come out and work with us, but we have great difficulty in getting men to be involved.
Over half the men, 57%, couldn't name a single symptom that might be caused by prostate diseases. People think that as you grow old, it's just natural that you have problems urinating or problems with erection. They don't really understand that these problems can be due to specific diseases that can be diagnosed and treated. This is not a case of what's right or wrong, but what really reflects your values and your family values, and that's what I'm here to help with. Hello, I'm Dr. Peter Scardino. I'm a urologist, and I want to talk to you about some special health concerns that will affect almost every man sometime in his life. We're going to talk about the common problems of the prostate, about prostate infections and enlarged prostate, and particularly about prostate cancer. And we're going to talk about male sexual dysfunction or impotency. I want to try to provide you with some information that I hope will help you make the best decisions about your own health, and I really believe will help you improve the quality of your life and enhance the length of your life. Let me tell you a little bit about myself first. I'm a urologist. I practice medicine in Houston, Texas. I'm the chairman of the Department of Urology at Baylor College of Medicine there. I went to medical school at Duke University and finished my training in urology at UCLA. I spend most of my time with patients, seeing patients in the office, operating. I've done about 1,000 operations for prostate cancer. Teaching's also an important part of what we do. We have medical students who work with us all the time, residents who work every day in the operating room, and I travel frequently around the country teaching in cities here in the United States and around the world. Urology is the branch of medicine that deals with the male and female urinary tract, all the way from the kidneys that produce the urine down through the plumbing that takes it to the bladder and right out through the urethra. But we also deal with the male genital organs, the penis, the prostate gland, and the testicles. Now, urologists are surgeons, but they're also diagnosticians. Urologists evaluate problems in these areas and try to recommend the best solutions, whether that's medicine, whether it's surgery, or whether it's just often reassurance. You might ask why we're doing a program like this, but I think a better question would be, why don't you see more programs like this? Certainly there have been a lot of programs lately about the special health problems of women, and the health problems that occur in the male organs are no less important. Did you know, for example, that there are 10 million American men who have problems with impotency? Benign enlargement of the prostate is even more common. 8 out of 10 men will experience benign enlargement of the prostate sometime during their life, and 1 in 4 of them will need surgery for it. And prostate cancer has become the #1 cause of cancer in American men. This year we expect 200,000 men to be diagnosed with prostate cancer, and 38,000 are expected to die of the disease. Both benign enlargement of the prostate and prostate cancer are diseases that are age-related. So as the American population ages, we're going to see more and more of these kind of problems. Nevertheless, you don't tend to hear very much about them. I had a patient in the office the other day, a 51-year-old man who had just been diagnosed with prostate cancer, and he was really feeling pretty low about it. He came in the office and said, I don't understand this. I've done all the right things all my life. I've watched my diet, I exercise regularly, I've never smoked, I rarely drink. There's no one in my family who's ever had cancer. How could this have happened to me? I've got a cancer in an organ that I didn't even know I had until recently. Well, prostate cancer is not a disease like heart attacks or lung cancer that you can do something to prevent. This is a disease that you need to know about, be aware of, and doing the right thing means going in and getting a checkup. If you're a man over the age of 50, getting a regular checkup is a way that you avoid a serious health problem from prostate cancer. This whole area has been shrouded in a lot of myths and confusion. These have been taboo subjects. People feel that they can't talk about them because they have a certain sense of guilt that they must have done something wrong. If they have a problem that goes wrong in this area, if they're having difficulty with erections, it must be their own fault. They have a bad marriage or something. There's also been a problem with education. Male health has not really received the same attention in the schools as women's health issues, and women seem to become more conscious and aware of their health and their bodies early in life because they experience changes like menstruation and childbirth early on. They become comfortable talking about their health and seeing a doctor about health problems. But the problems that men get into tend to occur later in life when they've already gotten the habit of not really talking about them or sharing them with each other. I think most of the women in the audience would recognize that if they get together with each other, it's not that unusual that they talk about some pretty personal and intimate things. But what do men talk about when they get together? They're much more likely to talk about football or going fishing. They don't often sit around and talk about having a little trouble getting an erection. I think maybe some of this is about to change. Men seem to be becoming more aware of their bodies. There's a lot of high-profile men who've come out recently courageously willing to talk about their health problems in these areas. Maybe men with a little help and prodding from the women who care about them are ready to learn more about their own bodies and the things that go wrong with them. So we're going to talk today about the common problems that occur in these areas, about male sexual dysfunction or impotence, about the common diseases of the prostate, particularly prostate infections, benign enlargement of the prostate, which we call BPH, and we're going to spend a lot of time talking about prostate cancer because this is the killer disease. This disease can be cured if it's caught, if it's detected early and treated properly, but if not, it can get into an advanced stage and become lethal. I want to try to give you information that will help you to make the decisions about your own health, that will give you the opportunity to do things to enhance the quality of your life and even the length of your life. Now let's begin this by looking at some of the anatomy in this area. I'm a surgeon and I think it's very helpful to understand what goes wrong in these areas if you really appreciate how these organs are arranged and how they relate to each other and why they might cause some of the symptoms that they do. This is a drawing of half of a man's body. It's like it was cut right in half down the middle, and you're looking in from the inside, so you're seeing the right half of the body. Here's the urinary tract, the kidney that makes the urine on the right side, the ureter that drains the urine down into the urinary bladder. The urine is stored in the bladder until you're ready to empty it, and then the urine flows out through this tube called the urethra. Now let's take a careful look at the pelvic anatomy down in this area. We'll look at this in a close-up view. Here's a close-up view. Again, the urinary bladder, which is kind of the storage vehicle that holds the urine. The bladder is a muscle, and as the bladder fills up with urine, when you're ready to expel it, this muscle contracts. But in order for the urine to flow out through this channel, it has to flow through this sphincter. The sphincter muscle has to open up and relax and allow the urine to flow out. Right around this sphincter muscle, this inner sphincter muscle, and really part of it is the prostate gland. The prostate is a walnut-sized organ that wraps around the urethra, and the job of the prostate is to produce the fluid that bathes the sperm and keeps the sperm healthy. This fluid is stored in the seminal vesicles right here next to the prostate gland and comes out at the time of an ejaculation. The sperm themselves are produced down here in the testicle, and the sperm get up into the area by flowing through this tube called the vas deferens into the ejaculatory duct, where they mix with the fluid from the prostate and the seminal vesicles. Now, if you have a vasectomy, you'll have this tube blocked off right here, so the sperm can't get to the outside world. Well, let's take a look at the anatomy of the penis, because this is a poorly understood area. The penis has three compartments to it. It has, on the bottom, where the urethra is, where the urine flows through, this is surrounded by spongy tissue that's full of blood vessels, and this connects right through to the head of the penis. On the top of the penis, there's two large bodies, the erectile bodies, that fill with blood to cause an erection. These are also filled with spongy tissue, and they're lined by a thick leather-like lining. Now, what happens when an erection occurs? Let's take a look at that. Here's a picture of an erection. This is the penis when it's erect, and you can see these same bodies, this large erectile body on the top, the smaller spongy tissue on the bottom here are now filled with blood. The way an erection occurs is basically blood flows in through these large blood vessels that are controlled by nerves. These fine nerves tell the blood vessels to open and allow a rich and rapid flow of blood to come into the penis. So in humans, there's no bone in here. It's just the penis is made stiff by being full of blood and being held in by this leather-like lining of the erectile bodies. When an ejaculation occurs during sexual activity, the fluid produced by the prostate and the seminal vesicle is forced out into the urethra here between the bladder and the penis, and the inner sphincter muscle, the back door, closes. The front door, the lower sphincter muscle, which is important, we'll talk about that later when we talk about treating prostate cancer, this outer sphincter muscle relaxes and allows the semen to flow into this part of the urethra. Here, surrounding the urethra between the scrotum and the rectum are some muscles that then force the fluid out all of a sudden, and that's what we experience as an ejaculation when the fluid suddenly comes out of that area. Now, normally, a sense of climax or orgasm occur at the same time, but really these are three separate events. Let's take a look at that for a minute. Male sexual function is really the integration of orgasm, ejaculation, and erection, but this is not just one single event. Men tend to think of these things all happening at once, but certainly you can get an erection without having an orgasm or an ejaculation. In fact, you can have an orgasm without an erection or without ejaculation. An orgasm is something that occurs in our brains. Ejaculation depends upon the nerves going to the prostate and the muscles around the urethra to force the fluid out and along the urinary channel, the urethra. An erection depends upon mainly blood flow, a rich supply of blood vessels that can allow blood to flow into the penis, and that these blood vessels are under the control of some fine nerves. When we talk about male sexual dysfunction or impotence, what we mean here is the inability to get or sustain an erection of the penis that's adequate enough for sexual activity. We're not talking about loss of libido, loss of sex drive. That's a separate problem and has other reasons for it. And we're not talking about premature ejaculation or the inability to ejaculate. We're really talking about loss of the ability to have an erection. Now let's look at some figures about this. 10 million people were estimated in the Kinsey report a number of years ago. 10 million American men were estimated to have a problem with erection. A recent study in Massachusetts showed that there are probably twice that many. Beginning at age 40, about 2% of men every year will gradually lose their ability to have an erection. So by age 60, 40% of men will have this problem. By age 80, 80% of men will have this problem. So there's no question that impotence is an age-related event. This can be a devastating problem for some men. For others, it's something that they can adjust to quite well. I had a patient come in the office the other day, and I told him that he may well have to have an operation that, could interfere with his ability to have an erection. And he said, well, that's all right, Doc. Is it going to interfere with my golf game? So, each person has their own values about how important these things are. To some people, this can be a pretty devastating problem. What are the causes of loss of erection? Well, although age makes you more susceptible to it, the major causes have to do with blood vessel diseases, the same kind of problems that can interfere with blood flow to the heart and cause a heart attack. Everybody's heard of atherosclerosis or hardening of the arteries. That same thing can occur in the blood vessels that go to the area of the penis. When these blood vessels get blocked off, They can't open up and allow a flow of blood to come in, and so this can interfere with erections. High blood pressure, and the medicines that we take for high blood pressure can be a serious source of problems with erection. Diabetes is a major problem. Diabetes interferes with the function of the fine nerves that regulate these blood vessels. Cigarette smoking is a preventable cause of impotence. Men who smoke all their lives are more likely to have problems with erection later in life than men who don't. Alcohol, even Shakespeare recognized that alcohol can sometimes stimulate the will but interfere with performance. And in the short run, it often does that. In the long run, chronic alcohol abuse can cause nerve damage that can permanently interfere with the ability to have an erection. One thing that a lot of men will experience is temporary problems with erections. They're okay under some circumstances, but not really very good under other circumstances. This tends not to be due to an underlying disease, but more to stress, situational problems, emotional difficulties, and that's why when we start thinking about the different treatments for impotence, counseling is one of the most important. And I'd like to review for a minute the different ways that we have of treating these problems. When a doctor sees and evaluates a patient who complains of impotence, one of the first things we try to do is learn whether this is a permanent problem that occurs under all circumstances, or is it situational. If it's situational, counseling is often the right thing for that kind of a problem. A medicine that would help erections would be a great thing. I mean, if I had invented a medicine that could give everybody a great erection all their life, I don't think I'd have to worry about doing much else. But unfortunately, there's not any really good medicine that will do that. There's some drugs that are available. There's one called yohimbine that's a kind of general stimulatory drug, and we sometimes prescribe it, but it's not all that powerful. Really, whatever the cause of impotence, there's three major ways to treat it nowadays that are very helpful, and I'd like to show you about these: vacuum devices, injections, and prostheses. Let me start out telling you about a vacuum device, and I brought one today to show you so you wouldn't have to just use your imagination about what this is. I admit it seems like a fairly awkward deal, but it's a very simple idea. A vacuum device is just a plastic tube that can be placed over the penis, and there's a pump. This pump mechanism is attached to it by this tubing, and by pumping this, you create a vacuum in here that simply draws the blood into the penis. This vacuum then by drawing the blood into the penis, you can trap it there by taking this rubber band and putting it around the base of the penis. So it's like putting a tourniquet on. It traps the blood in the penis, and of course that means there's not a rich flow of blood into the penis. The blood is trapped inside, so it'll give a very firm erection, but the penis will be a little bit blue and a little cool compared to a normal red, warm penis that comes about from a normal erection. Remember that part of the erectile bodies actually goes inside, and the rubber band is only around the part that's on the outside, so the erection is a little bit floppy compared to a normal erection as well. So it's not entirely natural, but it's actually very workable. It's simple, it's not expensive, there's not much risk or complications associated with this device, and I think it's something that really has been a real big advance. Now the second area always kind of gets a nervous chuckle out of my patients when I tell them about the injection program. This is the idea of actually learning how to give yourself an injection of a small amount of medicine into the penis, and not very many men take well to the idea of sticking a needle in themselves. But actually, when you learn about this, it's not really such a bad idea. I always tell the patients that we're going to use the smallest needle known to man, and you just inject a very tiny amount of medicine. These medicines are vasodilators. They open up the blood vessels that go to the penis, and you just make a little prick with the needle, inject the medicine, and this will cause a rich flow of blood into the penis. The advantage of this kind of approach is that you're basically giving yourself an erection like Mother Nature, but you have to remember that the erection will last until the medicine wears off. I was talking to a couple about this and explaining to them how to use this, and I said, on average, an erection will last about 35 minutes with this, and his wife looked up and said, well, honey, that's 30 minutes more than we need. So you have to learn to use it and adjust it to your needs, but you can do that at home. You can take more or less, and you're pretty safe out to about 3 or 4 hours. Beyond that, it's time to come in and get the antidote, and we have good ways to reverse it if we need to. The last area I'd like to talk about is prostheses. This is kind of the last resort treatment that involves a surgical procedure, but let me show you what it looks like when we implant a prosthesis into the penis. This is a complicated drawing, but I think if you bear with me and look closely, you can see here the erectile bodies that I showed you before. Remember, half of the penis really is inside the body. The other half is outside, but the erectile bodies go all the way down inside, and when we implant one of these prostheses, we make an incision over the penis and scrotum, and we put these rods in the erectile bodies on each side. And in this particular type, which is called an inflatable prosthesis, we actually implant a cylinder into the penis, a pump, and a reservoir. And I brought one of these to show you what this looks like. This is a very simple plastic device. These are the cylinders, this is the pump, and this is the reservoir. So this device can be completely implanted inside. You don't even know it's there. Nobody could tell by looking at you. And what you do is, by pumping this bulb here, you transfer fluid from the reservoir into the cylinders, and the cylinders then fill up and become stiff. And then when sexual activity is over, then you simply push a release mechanism, and they just come down and collapse. So this is a very natural kind of prosthesis. There are other kinds that are simple rods that can be placed into the penis. These rods can bend up and down, and rather than deflate and inflate. But the advantage of these prostheses is that once they're put in, they really last a lifetime. There are problems with it. This requires a major surgical procedure. There is a risk of infection. There can be mechanical breakdowns with these, but generally they're very satisfactory. 90% of men and their sexual partners report satisfaction with this. So I think you can see that there are effective treatments for the problem of impotence. People think that as you grow old, it's just natural that you have problems urinating or problems with erection. They don't really understand that these problems can be due to specific diseases that can be diagnosed and treated, or that there's treatment for these conditions even if there's not an underlying disease. This is a problem that really seriously interferes with the quality of life for many men, but if you go in and get a checkup and get one of these treatments, I think you'll find that this will enhance the quality of life in an important way. When we return, we'll move on to the subject of benign prostate enlargement and its treatment options. But now, please call this station to show your appreciation for this program with your tangible support. Thank you. There was a recent poll taken among American men that showed 11% of them, 1 out of 9, didn't even know what a prostate was or that they had one. Over half the men, 57%, couldn't name a single symptom that might be caused by prostate diseases. Yet prostate diseases are among the most common problems that men experience, not only as they grow older, but there are even some that occur when they're young. Prostatitis is something that I'd like to talk about first. Prostatitis means an inflammation of the prostate. You've probably heard about laryngitis, an inflammation of the larynx. Well, that's all prostatitis is an inflammation of the prostate. There are many different causes of it, but let me tell you a story about a patient who came in the office so you can get an appreciation for what symptoms it caused. A young man came in, he was in his late 20s, been healthy all his life, and woke up that morning with severe pain in the lower abdomen area and in his bottom underneath the scrotal area. And he had difficulty urinating, pain and burning when he urinated, and he felt pain at the tip of his penis. He came to the office, and I found that he had an infection in his urine and in his prostate gland. This is what we call acute bacterial prostatitis. This is just like having a strep throat. It's due to a bacterial disease, a bacterium that gets into the prostate gland and causes a tremendous amount of pain and inflammation in the prostate. And we treat this in a pretty straightforward way with antibiotics, just like we treat a strep throat, for example. But this doesn't always work. Sometimes this acute prostatitis can turn into chronic prostatitis, which means that it comes back over and over again. It can be very difficult to get rid of these bacteria that get inside the prostate gland that seem to like to hide in the little glands within the prostate, and it's difficult to get antibiotics in there to eradicate these. Patients who have chronic prostatitis have a similar type of problem or similar type of symptoms to acute prostatitis, but usually they're not so severe. These symptoms tend to come on a little bit more slowly. They aren't as disabling. You're not likely to have fever and chills and be acutely ill, but you're going to have a lot of discomfort and a lot of pain in the area of the lower abdomen again, pain on urination, frequent urination, and this requires a longer course of antibiotics, and preferably an antibiotic that's specific for the type of infection you have. So it's important to go to the doctor, get a sample of urine or of prostatic fluid, send it to the laboratory for culture, and find out exactly what kind of infection it is so that the antibiotic that you take will get rid of the infection and that you can take a long enough course of it. We usually recommend 6 weeks of it. Now, sometimes prostatitis will occur in a non-bacterial form. What this means is you've got all the signs and symptoms. There's even evidence of pus cells in the prostatic fluid if we look at it, but there's no bacteria. There's no infection that we can identify. Antibiotics don't seem to cure the problem, and really there's no good definite treatment for non-bacterial prostatitis. We usually recommend hot tub baths and an anti-inflammatory drugs, the same kind of drugs that you might take for arthritis, for example, to help relieve the symptoms. Finally, there's a form of prostate problem called prostatidynia. That's a long medical word that really means pain in the area of the prostate, and we really don't think that probably has anything to do with the prostate. It's probably more a muscle spasm of the muscles down in the pelvis and the area of the prostate. It can hurt awfully bad. It can be a source of misery, but you don't find any sign of infection, you don't find any sign of inflammation, and antibiotics are not going to help it. Usually we treat this with muscle relaxing drugs, sitz baths and reassurance. Sitz baths or hot tub baths and reassurance, because we can certainly tell someone this is not likely to be something that's going to make you real sick. It's not something that's going to threaten your life, but it can be a source of a great deal of misery. Now, let's talk about the most common problem that occurs in the prostate gland, benign prostatic hyperplasia, or we like to call it BPH. Now, BPH occurs when the central part of the prostate overgrows. Let me show you a picture of that to help understand exactly what this looks like. Again, I think it helps if you realize that it's the central part of the prostate that overgrows in this condition of BPH. The true prostate gland here is actually pushed out by the enlargement of the inner part of the prostate, and you get a situation that's much like an orange. The true prostate is like the rind of the orange, and the pulp of the orange is the abnormal overgrowth of tissue in the middle. This abnormal overgrowth can cause problems for 2 reasons. Either just simply a mechanical blockage of the channel, there's just tissue there that's in the way, or it can be a problem of a failure of this tissue to relax. Remember, the inner urinary sphincter and the prostate have to relax during voiding in order to allow the urine to flow out. And sometimes this muscle is so rich and tense that it just won't relax and allow the urine to flow out. This growth of the prostate gland is really remarkable. If you think about it, the prostate gland, which is under the control of male hormones, starts out in a child the size of a bean. But with the rise in male hormones that comes along with puberty, the prostate begins to grow and becomes the size of a walnut. It remains that size until about age 40, when it gradually grows larger and can grow up to 4 or 5 times the size it was when you were 40 years old. Now imagine if that same thing happened to your ears. I mean, imagine if your ears when you were 40 years old started growing and growing. By the time you were 60 or 70, were 4 to 5 times larger. I think that would attract a lot of attention. Well, the prostate gland does that in almost everybody as they age. Sometimes it will grow steadily and get larger and larger with age. Sometimes it will grow a bit and then level off, and occasionally it won't grow at all. We don't really understand what makes it grow. We do know that male hormones are important, but actually beginning at age 40, there's a drop in male hormones, but there's also a little bit of a rise in female hormone levels in men, and we think maybe it's the ratio of the male to female hormones that particularly stimulates the growth of the prostate gland, but we don't really know that for sure. Now, it's interesting that the only mammals, the only animal species that get enlargement of the prostate are human beings and dogs. We can't find this problem in any other animal. We do know that it's age-related, but we don't really know what it is about aging that causes it to enlarge. When it does enlarge, the symptoms that it causes are, I think, very familiar to many people. The kind of symptoms we think of, the difficulty urinating that many old men get, a slowing in the size and force of the urinary stream, some hesitancy in getting the stream started. You notice that it's taking you a lot longer to go to the bathroom than it used to, and the young guy next to you seems to finish pretty quickly. Sometimes the stream will stop and start, and oftentimes people will complain of waking up at night to urinate. These are the classic symptoms of an enlarged prostate gland. Now, if this goes on for a long time, it can lead to serious medical problems. For example, your urinary tract can get completely blocked off, and you can be unable to urinate at all. You can get predisposed to urinary infections or stones in the bladder or bleeding from the prostate gland. If it continues to advance, it can block off the kidneys and lead eventually even to kidney failure. Of course, that was something that used to occur many years ago before we had modern medicine, but you don't see that very much nowadays. But I've seen pictures of for example, cowboys who used to keep a little reed in their hat, and they would occasionally use this to pass right through the urethra in order to allow them to empty their bladder. There was nothing else that could be done about it in those days. But today, those kind of serious medical problems are fortunately pretty rare. By and large, the problem that drives men into the doctor nowadays is the symptoms, the inconvenient symptoms that I talked about earlier. But it's important to understand one of the confusing or complex things about this disease. The symptoms it causes are not just simply related to the size of the prostate. You can get a large prostate gland with no symptoms at all, or you can have very severe symptoms with a relatively small prostate gland. There are really four parts of this problem of BPH. There's the enlargement of the tissue in the central part of the prostate gland that 8 out of 10 men will get during their lifetime. There's the symptoms that sometimes go along with that we call prostatism, the symptoms I described for you just a minute ago. Then there's the actual blockage of the channel. How much blockage is this causing? Sometimes it doesn't cause very much blockage at all. Sometimes it's severe. And finally, how is the bladder responding to that blockage? Those four things together, when they occur, are what we would call classic BPH, but they don't necessarily all occur at the same time. When you go to a doctor for an evaluation, for example, I had a patient who came to the office the other day, and he said, well, my doctor wanted me to come in and have you check me because he said my prostate was enlarged. And I said, well, are you having any problem urinating? No. Has your urinary habits changed in the last 5 years? No. I examined him. He did have an enlarged prostate, but I told him to go his way and not worry about it, that an enlarged prostate is not in and of itself a disease. It's the symptoms and problems that come from it that we worry about. When you see a doctor for this, oftentimes the doctor will start the evaluation by asking you to fill out what's called a symptom score card. It's a way we can get an objective measurement or a number that can tell us how severe your symptoms are. Also, we want to know how bad do these symptoms bother you. One man may come in and say, well, you know, I'm waking up 3 times a night to urinate, my stream's awfully slow, what can I do about it? Another man I saw in the office, I said, how often are you getting up at night? He said 3 times. How's your stream? Well, it's pretty slow. Well, would you like to do something about it? No, it's not bothering me at all. I'm used to it. So it's not just the symptoms, it's how bad those symptoms are bothering you or causing you a problem that should lead you towards what kind of treatment you should have. Your doctor is probably going to want to check a urine specimen. He'll want to get a blood sample to see that the kidney function is okay, and probably to check this PSA test, or prostate-specific antigen, that we're going to talk about a little later when we talk about prostate cancer. And these tests will allow your doctor to estimate how serious is this problem, is it due to an enlarged prostate or another condition, and how should it be treated. Now let's take a look at the various treatments for enlarged prostate, because there are some very effective treatment strategies for it. And I've outlined them here: watchful waiting, medical treatment, and surgical treatment. And let's take a look at each of those. Remember that the goal of treating this problem is relieving symptoms. It's not necessarily to make the prostate smaller. You're not going to necessarily be any better off just because your prostate's smaller rather than larger. So many times when men come in complaining of the symptoms that I've talked about, after an evaluation, we decide that the best thing to do is just nothing. Just watch it along. Come on back in 6 months or a year. Let's check you again. Let's come back next year. And if things begin to get worse, or if one of these unusual underlying medical problems occurs, then we'll go ahead and start treatment. Other men, if they're bothered by the symptoms, are good candidates for medicines. Let me tell you about the different kind of medicines that are available, because these have just been approved for use in the last few years, and there are two entirely different ways that these medicines work. There's one group of medicine that we call alpha blockers. An example of these, the chemical names here, terazosin and doxazosin. Now, it's not important that you remember these. Your doctor will be familiar with the names of them, but these drugs are the same ones that are used to treat high blood pressure, and they work by the same mechanism. High blood pressure can be lowered if you take a medicine which will relax the smooth muscle in the wall of the blood vessel. And this does the same thing in the prostate. It relaxes that muscle in the prostate and the opening of the bladder, that inner sphincter that we've been talking about, and allows the urine to flow more freely. So these medicines don't do anything to the size of the prostate, but they relax the muscle tone of the prostate. And the nice thing about them is that they work fairly quickly. You start taking a low dose of them, you gradually build up to the highest dose that you can reasonably tolerate, and you know within a few weeks or a month whether or not you're going to benefit by this. About 1/3 or 1/2 of men who take these kind of medicines will get better, but the other ones won't get much benefit out of them. The side effects are drowsiness, dizziness, and when you stand up, what we call postural hypotension. That means you get dizzy if you stand up too quick. So we recommend that you take this at night before you go to bed. The other main class of medicines are medicines that suppress the hormone level. Now, it wouldn't be a very good idea to take a medicine that would completely knock out the male hormone. Not many men would trade loss of sexual function for a little improvement in their urinary symptoms. But there are medicines nowadays that can actually block the conversion of the normal male hormone into the special form of the hormone that stimulates the growth of the prostate. And one of these drugs is called finasteride. That's widely available now. You take it once a day. It rarely, 2 or 3% of men will have an effect on their sexual function. It's reversible if you stop it. But the point of this medicine is to shrink the size of the prostate gland. About half the men who take the medicine will get some benefit. The prostate will shrink by about 30%, but it takes you 6 months, 3 to 6 months, to know whether or not you're going to benefit from the medicine. Finally, I'd like to talk briefly about surgical treatment of the prostate, because this is kind of the last resort. If watchful waiting is not right for you, if your symptoms are too severe and medicines don't help, surgical relief is the way to go. Now, basically, the idea here is that a doctor will do what's called a transurethral resection of the prostate, or a TURP operation. What you do here is simply pass this telescope through the channel transurethral. You can see the blocking tissue and literally just scrape it out. Some people call this a roto-rooter operation. You scrape it out, and the inner sphincter muscle is taken out as well, and so you have a nice wide open funnel for the urine to flow out. 80 to 90% of men who get this kind of treatment are very satisfied with it. They urinate very well again. but there are side effects. This is major surgery. It will cause what we call retrograde ejaculation. That means that when the fluid from the ejaculation comes into this area of the urethra, because the inner sphincter or back door can't close, the fluid will flow back into the bladder and dissolve in the urine. So when you experience an orgasm, the fluid won't come out. This isn't harmful. It'll wash out the next time you urinate, but it is a change that you should be aware of. There's new technology now. These operations can sometimes be done under laser control. There are limited operations called a transurethral incision of the prostate. But I think that you can see that there are a variety of different treatments for the problem of an enlarged prostate, treatments that will make a big difference in the quality of your life. We'll be back to discuss how early detection of prostate cancer can save your life. But now, please call this station with your pledge of financial support to show your appreciation for this show and others like it. Thanks.
This program is made possible by the annual financial support from viewers like you. Additional funding for Straight Talk on prostate health is provided by HealthNet, California's health plan. HealthNet is proud to support this program, which encourages wellness for men in all stages of life.
Prostate cancer is now the #1 cause of cancer in American men. 200,000 men this year will be told they have prostate cancer, and 38,000 will die from the disease. It's the second most common cause of cancer death, second only to lung cancer, and lung cancer is a preventable disease, but prostate cancer is really not. If you think about those statistics, it means that every 3 minutes this year, one man's going to be told that he has prostate cancer, and every 15 minutes, someone's going to die from that disease. So this is a devastating problem that's become unbelievably common. Yet it's a cancer up until recently that we seldom heard about. But recently, for several reasons, prostate cancer has begun to make a little bit of the news, the kind of news you would expect for the #1 cancer in men. Part of that reason is because some high-profile men have come forward and told the stories about their prostate cancer. Men like Senator Bob Dole, Jerry Lewis, the actor, I think Frank Zappa died of prostate cancer recently. So we're reading more about prostate cancer in the newspaper, but another reason why prostate cancer is getting more attention is because there's been a remarkable new test that for the first time has really given us the ability to detect this cancer earlier when it's still in a form when it can be treated, and that's the prostate-specific antigen test, or PSA test. PSA has really been quite a remarkable advance. It was approved in 1986 for monitoring the course of prostate cancer to treatment, and it was approved in 1994 for screening and early detection of prostate cancer. Because of the PSA test and the new ways of taking biopsies from the prostate, we're finding many more cases of prostate cancer than we did. For example, the number of cases per year has doubled in the last 5 years. We expect that there's 1 million American men right now who have prostate cancer and don't even know they have it, but it could be detected with this kind of testing. Now, no one really knows what the cause of prostate cancer is. It's one of the most controversial and poorly understood cancers, and there has not been enough research support for prostate cancer to provide the information that we really need to know about this disease. We don't know what causes it, but we do know that there are certain risk factors. Certainly, age is one of the most important risk factors. Prostate cancer increases with age faster than any other cancer that we know. So as the population ages, we're going to see more and more of it. We know that ethnic background or racial group is an important risk factor for prostate cancer. For example, Japanese or Asians have a very low incidence of prostate cancer, while African Americans have the highest incidence of prostate cancer of anybody in the world and one of the highest death rates. For African American men, this is the #1 cancer killer. We know also that family history of prostate cancer is an important risk factor. We've learned that if you have a brother or father who has prostate cancer, you're twice as likely to develop the disease. And if you have 2 first-degree relatives, a brother and a father, for example, you're more than 10 times more likely to develop the disease. Prostate cancer runs in families usually in a young form. So if a man is diagnosed with prostate cancer under age 55, about half the time that means that he has a form of prostate cancer that runs in families. Now, other possible causes of it, dietary factors maybe. We know that if Japanese, who have a very low incidence of prostate cancer, move to this country, they adopt more of a Western diet, their risk of getting prostate cancer goes up, their children is even higher, and their grandchildren is almost the same as Caucasian Americans. We think that vitamin D may possibly play a role in prostate cancer. We know that as you go towards northern climates where sunlight exposure is less, the chances of developing prostate cancer go up. And we think it's because sunlight causes the formation of vitamin D, and with low vitamin D levels, we think you may be at greater risk of it. This is new information, it's speculative, but it might provide new hope for ways to prevent prostate cancer. If we could find out some of these factors in the diet or some of these vitamins that are important in the cause of it, we might be able to supplement them and prevent it. There's actually a large trial underway to see if certain hormone agents, we talked about finasteride, the drug that's used to shrink the prostate, is now being tested as a possible way of preventing prostate cancer. You know, I think it's important to understand this disease, to look at it and where it arises in the prostate gland. So let's go to our charts and let me show you a picture of an early prostate cancer. You'll recall that this is the bladder, here's the prostate gland. Cancer of the prostate gland tends to arise on the outside of the prostate, much different than BPH, benign enlargement, which occurs on the inside or the inner part of the prostate. Cancers tend to arise on the outer part of the gland. These are relatively slow-growing cancers. They might take 2 to 4 years to double in size. On average, it takes about 10 years, if a cancer is discovered like this, before it will spread to the bones, and the average man will live for about 3 years after that. It takes 10 to 15 years from the time an early prostate cancer could first be detected until it's likely to spread and result in the death of the person who has it if it's not treated. Now, there are important ways to detect these cancers, and probably the most important and time-honored way is what we call the digital rectal examination. The digital rectal examination is really a simple office procedure where the doctor places a lubricated, gloved examining finger in the rectum. We can feel the prostate gland and oftentimes feel this firm nodule on the prostate gland. We teach our medical students that when you do this exam, a normal prostate feels like the soft muscle of the thumb. Benign enlargement of the prostate feels like that muscle when you squeeze your fingers together. It's kind of firm and rubbery. Prostate cancer feels like your knuckle. It's bony hard. So you can easily recognize the difference. Now, another important test in determining the presence of prostate cancer is the prostate-specific antigen test. The PSA is a simple blood test. It's inexpensive, and PSA has proven to be even more accurate than the digital rectal examination in detecting prostate cancer. PSA was first discovered in 1979. It wasn't until the late 1980s that we began to appreciate how powerful it was for monitoring the course of a prostate cancer. If the cancer grows, the PSA usually goes up. If the cancer responds to treatment, the PSA usually goes down. If you remove the prostate, there should be no PSA detectable at all anymore. So the PSA level is very important in helping us to diagnose cancer. If the PSA level is above 4 in the normal, most common assay that's measured, you have a 1 out of 4 chance of having prostate cancer. If it's above 10, you have a 1 out of 2 chance of having prostate cancer. So this is a very accurate test, certainly as accurate as mammography or other tests for detecting cancer. Now, in addition to the PSA test, if either the digital rectal examination or the PSA test are abnormal, usually the next step is to have an ultrasound of the prostate gland. The ultrasound provides an image of the prostate. You can see it. Sometimes you can see a cancer in the prostate, but more importantly, the ultrasound can be used to help you guide a needle into the prostate to take a biopsy or a sample of tissue. Today, that can be done in the doctor's office. You can even take multiple samples of tissue from the prostate. We typically will take 6 or 8 samples at one setting, and honestly, although it's not such an attractive idea, it's not much worse than going to the dentist. Most men find they feel a little pressure or discomfort from it. There's a small risk of some bleeding or an infection afterwards. You try to prevent that with antibiotics. But the ability to take these multiple tiny samples of tissue from the prostate have revolutionized the diagnosis of this disease. One of the important things that we do with that tissue when we remove it is find out if the cancer is present and then ask the pathologist to give us a grade of the cancer. Grade means how malignant does the cancer look under the microscope? How aggressive is it going to behave? And the most common grading system is the Gleason system. It goes from a low of 2 to a high of 10, so 6 is right in the middle. And the way we assess how serious a problem prostate cancer is by the grade of the cancer under the microscope and the stage or the extent of the cancer measured best by the digital rectal examination. Despite these new tests, there's still a tremendous amount of controversy about whether early detection and treatment are beneficial for prostate cancer. The American Urological Association and the American Cancer Society, for example, recommend in favor of early detection, but the National Preventive Task Force does not. Why is there such a controversy about this disease? The reason for the controversy is several unique facts about prostate cancer that I'd like to go over with you. Number one, this is a slow-growing cancer. As I said, it may take 10 or 15 years to spread and kill you. This is not lung cancer that you'll die from in a year or two if it's not cured. Most of the men who get it are elderly. The average age at diagnosis is 71. So many men are at an age where they might not live long enough for this cancer to cause a serious problem. One of the most unique things about prostate cancer is that if you look in the prostate gland of men over the age of 50 who are perfectly healthy and walking around, 4 out of every 10 will actually have cancer cells in their prostate right now. And that's led a lot of people to say, we better not do PSA testing and rectal exam testing, because if we do that, we're going to find cancers in 4 out of 10 men. If you think about it, that means there'd be 8 or 10, 12 million men could be diagnosed with prostate cancer. But the fact is, these little areas of cancer cells are so tiny that these tests can't possibly discover them. I'm not worried about these 4 out of 10 men with these little cancer cells. I'm worried about the occasional one of those, about 1 out of 5 of those that really grows into the kind of cancer that can threaten your life and health. That's the kind of cancer we can detect with the digital rectal exam and the PSA level. Finally, the other reason why there's so much controversy is because there's never been a study that's proven beyond a shadow of a doubt that early detection and treatment of prostate cancer will save your life. We think it will. There's many good reasons to believe it will, but the studies just haven't been done yet. It's not that the studies were done and they showed there was no benefit. These tests for prostate cancer are relatively new, and the studies are just now getting started. It's going to take us 10 or 15 years before the studies are completed, and we can say, this is absolutely what you should do. In the meantime, our best bet is to get the best information we can, understand this disease, and make a decision for ourselves about how we're going to be treated. Now, it's informative, I think, to compare prostate cancer to breast cancer. These are kind of close cousins, and they have an amazing number of similarities. I don't think very many people would question the need to detect and treat breast cancer, yet prostate cancer is remarkably similar. Both of these cancers are under the control of the sex hormones. In men, the male hormone testosterone stimulates the growth of the prostate and prostate cancer. In women, estrogen very frequently stimulates the growth of breast cancer. Both of these have a similar incidence and mortality rate. You're almost equally likely to get these diseases or to die of them. There are 46,000 breast cancer deaths expected this year and 38,000 prostate cancer deaths. The average age at diagnosis is remarkably similar. For example, people think that breast cancer occurs in young women in their 30s and 40s, while prostate cancer occurs in old men in their 80s. But that's not true. The average age at breast cancer is 64 years. Prostate cancer is 71. So there is a slight difference, but not such a dramatic difference. And now that we have PSA testing, we're seeing more and more young men with prostate cancer. The stage or extent of the disease at diagnosis is very similar with these two diseases, and the survival rate is almost identical. Once you're diagnosed with prostate or breast cancer, the chances that you'll live 5 or 10 years, even with modern treatment, is about the same for each of these. So these two diseases are very similar, and we certainly feel that since breast cancer is a disease that should be diagnosed and treated, prostate cancer is one that should be taken seriously as well. Remember, the American Urological Association and the American Cancer Society recommend that every man over the age of 50 who's healthy and has a life expectancy greater than 10 years have a digital rectal exam and a PSA test every year. And if you're over 40 and you have a high risk factor, if you're an African American man or you have prostate cancer in your family, then you should be checked every year beginning at age 40. I think these recommendations should be taken very seriously. And when we return, we'll discuss treatment options and quality of life issues. I trust this information is valuable to you and your family. Please show your appreciation by calling the station now with your generous support. Thanks.
This program is made possible by the annual financial support from viewers like you. Additional funding for Straight Talk on Prostate Health is provided by HealthNet, California's health plan. HealthNet is proud to support this program, which encourages wellness for men in all stages of life.
The treatment of prostate cancer depends more than anything else on the stage or the extent of the disease at the time of diagnosis. We think of this disease as either being localized, confined to the area of the prostate and tissue right around it, as extensive, meaning that it's spread out to the adjacent structures, or advanced, meaning that it's spread to other organs of the body. Let's talk first about the treatment of cancers that are confined to the prostate gland, because here you have a number of treatment options. We're going to discuss the most time-honored standard treatment options, the ones that we have the most information about, but I'll mention some of the newer ones, the ones that we don't have as much information as we go along. Let's look first at watchful waiting. Watchful waiting for prostate cancer is a strategy that's been made popular in Sweden and the northern European countries. The basic idea here is that this is a decision that this cancer does not need to be treated for cure. The idea is that you'll watch it along and you're betting that this cancer will not spread and hurt a person or kill them until they would normally die of other causes. So watchful waiting is not treating it. This does not mean a deferred treatment. In other words, it doesn't mean, well, I won't treat it today, but I'll watch my PSA along, and if it starts going up and I get worried about it, then I'll go for the cure, because that may mean that the cure will be too late. But since it's a slow-growing disease, watchful waiting has been used by many people, particularly in older men. Now, I had a patient not long ago, an 81-year-old man, pretty healthy, who came over from Florida, and he had just been diagnosed with a small, well-differentiated, favorable-looking prostate cancer. His PSA level was 7, and I sat down and talked to him, and I said, gosh, you know, at your age, I'm not sure this cancer is very likely to hurt you. maybe it would be best if you go on a watchful waiting program. On the other hand, if that same man with that same cancer had been 51 years old, he might not be a very good candidate for watchful waiting. Why is watchful waiting a reasonable strategy for this cancer? Well, mainly because it is a slow-growing cancer. It can occur in elderly men, and there are treatments available if the cancer does begin to grow before we've cured it. For example, radiation therapy can be used to slow the growth of the cancer or shrink it. Hormone therapy, and we'll talk about that in some detail in a minute, can be used to put the cancer in remission. These things might not cure the cancer, but they certainly can slow the growth of it. So there are treatments available other than the curative forms of treatment. The advantages of watchful waiting are that you don't have to go through any of the risk of treatments. The disadvantages are that the cancer is going to grow, and it may well get beyond the bounds of cure by the time you actually go in and treat it, and you need to understand this at the beginning. The next approach that I'd like to talk about is radiation therapy. Radiation therapy means trying to kill the cancer cells with gamma irradiation. It's been around since the early 1950s, and it's really been perfected in these days. It's a very high technology approach. To get this treatment, you go in 5 days a week to a specialized radiation therapy center. It takes 7 weeks or 35 treatments generally to have the full course of treatment. But the nice thing about it is that you don't need to go in the hospital. You're not going to be out of work all that time. A lot of men are able to work. The side effects of it are relatively mild. If you go to a place that's really experienced by a doctor who knows how to give this kind of treatment, it's really remarkably safe. The side effects tend to be inflammation of the bowel that causes diarrhea. Sometimes you can get bloody diarrhea from it. 1 to 3% of men will get persistent trouble with the bowel over time, but generally these symptoms will last a few months and then gradually go away. The main advantage of radiation is that fact that it's so safe and it doesn't really take you out of commission or require an operation. The disadvantage is, how certain are we that this is really going to cure the cancer permanently? We worry about it when we can do biopsies of the prostate several years after radiation and still find cancer cells present in a substantial proportion of patients, maybe as many as a third or a half. We also worry when the PSA levels, which almost always drop down when radiation therapy is given, will gradually begin to start rising again 3, 4, 5 years after radiation therapy. The most recent statistics show that about half of the men treated with radiation therapy will have a rise in their PSA by about 5 years after the treatment. The third approach I'd like to talk about is radical prostatectomy. Now, radical prostatectomy is the term for an operation that means complete removal of the prostate and the seminal vesicles. And there's a variety of ways that this can be done. Let me show you a picture of what it looks like when the prostate is removed. The prostate is like a segment of the pipe of the urinary tract. Remember, the prostate wraps around the urethra and is between the inner sphincter and the outer sphincter. When we remove the prostate for cancer, we have to take the entire prostate out. We can't just take a piece of it out. And then the bladder falls down to fill the space, and the bladder is sewn to the urethra to reestablish the continuity of the urinary tract. Now, if you think about that, you can understand some of the reasons why the common side effects occur from this kind of surgery. In the first place, it's a major operation. There's always risks that go along with the major operation, bleeding and infection, although those risks are lower now than they were 10 or 20 years ago. The biggest problems that people worry about with this kind of surgery is, will they lose control of their urination? Will they become incontinent? And also, what effect will it have on their sexual function? Well, certainly taking out the prostate is going to interfere with the process of ejaculation. Without a prostate, you're not going to be able to make the seminal fluid, and consequently, when you do experience an orgasm, no fluid will come out. But because the nerves that control the penis and control blood flow to the penis run so close to the prostate gland, traditionally those nerves were damaged at the time the prostate was removed, and almost everyone lost the ability to have an erection. Nowadays, there's a technique called nerve sparing, where we know how to separate those nerves from the prostate, and if the cancer is small enough, we can sometimes remove the prostate gland, leave those nerves behind, and depending upon the age of the patient, the quality of his erections before the operation, the size of the cancer, and honestly the surgeon's skill in dissecting those nerves off and saving them, you'll have a chance of recovering erections after the operation. Most men will lose their erections with the operation, and over a period of 6 months or a year will gradually recover. Urinary incontinence is not nearly the problem that it used to be. Overall, about 1 to 2% of men will have serious, permanent problems with urinary control a year after this operation. But the average man will take 2 or 3 months after the surgery to recover normal urinary control. So there's a temporary period of loss of urinary control, even if it's uncommon that it's a permanent period. Now, fortunately, both these problems, urinary incontinence, problems with erection, are very treatable problems. We talked earlier in the program about some of the treatments for loss of erections. The prostheses, the vacuum device, and the injections, all of these work quite well after the operation or even after radiotherapy if you're one of the men who has loss of erections due to radiation therapy. Urinary incontinence can be treated usually with what we call an artificial urinary sphincter that can be used if the incontinence is severe and persists for a year or more, but only 1 in 100 or 1 in 200 men will ever need this. Now, there are other forms of therapy for prostate cancer. There's cryotherapy, or freezing the prostate gland. There's radioactive seed implants into the prostate gland, but considering the information we have about freezing, for example, we just don't know enough about the side effects, and we don't know how likely freezing is to get rid of the cancer permanently. So I've discouraged people from using these kind of treatments while we have so many other good alternatives. They need a lot more investigation before we're ready to recommend them. The radioactive seed implants are being used less and less nowadays now that we have modern radiation therapy. The original idea behind the seed implants was that you could put the radiation inside the prostate and let it come out and do less damage to the surrounding organs. But with modern external radiation techniques, that's really not much of a consideration, and seed implants are only used in about 3% of men who are treated for prostate cancer nowadays. Now, how do you make a decision among all these different choices? I often tell my patients that this is a time for a second opinion. Talk to the doctor who diagnosed your cancer, learn as much as you can about it, but it's a good idea to seek advice from someone in another medical specialty. For example, if you've seen a surgeon first, you might want to see a radiation therapist or an oncologist and learn as much as you can about this disease so that you can make the best opinion, you can make the best decision about what's right for you. A recent poll showed that most men want information one-on-one from their doctor, and that's really the best source of current contemporary information after you've read and learned about it yourself. Now, what happens if the cancer is not found in this early stage? Let's take a look at what happens when prostate cancer begins to become locally extensive. This cancer will grow steadily. It'll grow and fill the prostate gland. It'll spill over and spread outside of the prostate gland into the area of the seminal vesicles. From there, it'll often spread to the lymph nodes along the pelvis and then out to other sites, most commonly to the bones. Locally advanced prostate cancer, as illustrated here, is usually treated with radiation therapy. This is too big a stage of prostate cancer for surgery to successfully remove it. Radiation therapy can often control the disease, and sometimes, although not very common, it can actually cure it. We'll sometimes use combinations of treatment, hormone therapy plus radiation therapy, or radiation therapy followed by hormonal therapy. But the problem is when prostate cancer gets to this extent, it's rarely curable. Once it spreads to the bone, then usually the form of treatment that we use is hormonal therapy. We need to get a treatment that will get to the cancer cells wherever they are in your body, if they're in the bones or the lymph nodes or anywhere. And the mainstay of treatment for this is hormonal therapy. Since prostate cancer needs the male hormone in order to grow and spread, if you get rid of the male hormone, you can put the cancer in remission. And you can measure this by the PSA test, for example. It'll almost always drop dramatically after one of these treatments. Let's look at the different treatments for advanced prostate cancer. These two types, testicle removal and the medicines called LHRH agonists are really essentially the same. Since the male hormone is produced in the testicles, removing the testicles will get rid of the male hormone and lower the levels by 95%. You can accomplish the same thing by taking a shot once a month of a medicine called leuprolide or goserelin. These are the two drugs that are available in this country for treating advanced prostate cancer. The side effects are exactly identical because all these LHRH agonists do is they go to the pituitary gland and shut down the signals that tell the testicle to produce the male hormone. So you can shut off the male hormone with a shot, you can shut off the male hormone by removing the factory that makes them. Either way, you get the same effects on the cancer and the same side effects. The side effects of getting rid of male hormone are decrease in your sex drive, your libido, decrease in your erections, and about half the men who get this kind of treatment will have hot flashes, similar to the kind of hot flashes women get when they go through the change of life. Sometimes these are treatable. There's medicines you can use to suppress them, but most men find that these hot flashes are irritating but not really a severe problem. So the side effects of these kind of treatments are not as severe, for example, as chemotherapy. And unfortunately, chemotherapy is not much good for prostate cancer. It really doesn't, it's really not very active against this disease. Now, sometimes we combine these pills called anti-androgens along with one of these two ways of getting rid of the male hormone. The pill that's available nowadays is called flutamide. You take 2 pills 3 times a day, and this anti-androgen works by a different mechanism. Rather than getting rid of the male hormone, it goes to block the effect of male hormone on the cancer cells. So it seems to have an effect in addition to these other two, and generally if a man can afford it and if the side effects are not severe, we would recommend taking the anti-androgen in combination with the testicle removal or the LHRH agonist if you can do this. It's not for everyone, but there might be some small advantage in taking the two together. Now, one thing to remember is that even with this combination of treatment, it's rare that we cure the disease, but common that we provide years of benefit. The average man with this kind of treatment will live 3 years, but 10% of men will actually live longer than 10 years. So an occasional man will have a very prolonged survival with this. Whatever the form of prostate cancer that you have, the tumor presents a serious risk to your life and health. But the treatments that are available for it also have their own risk. Here we're looking at trade-offs between the risk of the cancer and the risk of treatment. Now, there's been a very interesting, sophisticated computer model that's been devised to try to weigh these risks and benefits, to try to figure out for any given man what might be the best way to treat his cancer. And I'd like to just go over this. The 4 elements that go into this sophisticated model are the risk that the cancer will spread, what's your life expectancy, how effective is the treatment, and finally, what are the complications that are associated with the treatment. These kind of computerized models can help us to weigh the benefits of treatment and the risk of treatment in populations of men until we get some of the large studies done to really tell us whether everybody should be treated one way or everybody should be treated another. But what I think is even more important about these decision analysis models, if you think about them for a minute, this is exactly what a good doctor should do when he sits down with you in his office and talks about your disease. When I see a patient in the office who has prostate cancer, the first thing I want to try to learn is how risky is the cancer that he's got? What's the nature of his cancer and how likely is it to do him harm? We try to figure out what his PSA level is and how much it's changed over the last few years, what the grade of the cancer is, how wild or malignant looking it is under the microscope, and I try to determine the stage or the extent of cancer. With that information, I can get a pretty good idea of whether there's a low level of risk or a high level of risk from your individual cancer. The second thing I try to do is to really take an honest look with you at your life expectancy. Sometimes this is hard to do. We don't live forever, and some of us have serious health problems which will shorten the length of our life or our expectancy of living as a healthy person. And I think you need to be very realistic about this in deciding whether the treatment is going to be of any benefit to you considering the threat posed by your cancer. The third area we talk about is the effectiveness of treatment, and here I try to talk about how effective are the different treatments, surgery, radiation therapy, in our institution, in our own hands. What are our results? How likely are we to get rid of this cancer permanently, or if we can't get rid of it, can we slow it down enough that it's not likely to bother you during the rest of your lifetime? And finally, I think we want to look at the real complications of the treatment and be very candid and honest about it, not gloss over everything, but really face what are the problems that can come with this. What are the chances that the treatment could cause a serious medical problem for you? What about incontinence and impotence and diarrhea and the problems that we mentioned? And I think when you put all those together, after we have a long discussion in the office, it's time for me to sit back and ask the patient, what's important to you here? What do you worry about? What are your own values? When you go home at night after you learn that you have prostate cancer, what worries you and concerns you? Are you worried about the cancer? Does it mean a great deal to you to get rid of this? Are you really worried about the side effects of the treatment? Let me tell you a story about a couple of patients that I saw lately that I think illustrate this. I had a man come in the office who was 72 years old, who had a prostate cancer that I thought was serious, and he came in to have surgery. And we sat down and talked about it at some length, and I said, you know, you're 72 years old. You're not going to live forever. If you think about your cancer, there's not a high chance that your cancer is going to grow and spread and cause you a problem in your remaining life. You know, maybe you should consider watchful waiting. And he said, wait a minute, doctor. The reason I'm here is because I want to be darn sure I don't die of this cancer. I want to know that I'm going to die of something else, and that's why I want you to treat me with surgery. Another patient came in who was 56 years old. He had a similar kind of cancer, and he came in, and I thought he was a very good candidate for surgical treatment. He had a localized tumor that we could remove, and I thought he'd be a good candidate for this nerve-sparing operation. But I told him in all honesty, even though we could do nerve-sparing with him, that about a third of men his age were not going to recover satisfactory erections after the operation, even though we did our very best to preserve the nerves while we were trying to cure the cancer. Well, when he heard that, he stood right up and said, well, then, you've got to come up with something else for me, because there's no way I'm going to live my life if I can't live it as a full man, and I'll just have to take my chances with the cancer. So this is where I find it very important to have a patient look into his own heart, consider his own values, and make the decision that's really right for him. This is not a case of what's right or wrong, but what really reflects your values and your family values, and that's what I'm here to help with. This is what I think is the best thing about the art of medicine, is really listening to the patients and have the patients tell me what it is that's most important to them after I've given them the very best information that I can. I hope that we've given you some information that will help you to make the best decisions about your own health, information that I hope will enhance the quality of your life and also the length of it. I thank you very much for your attention.